Welcome to the Healthcare Cure Podcast, a podcast dedicated to the bold mission of fixing healthcare. Now, here's your host, healthcare futurist, best-selling author, and adjunct professor, Nick Webb.
Welcome to another episode of the Healthcare Cure Podcast. Today, once again, I have my sidekick, a spiritual leader, and genius partner, Dr. Ray Power, with me today, and I'm really excited to find out that he brought in one of his colleagues on the Irish side to share some great ideas. And I love the fact that we have an international film here where we're getting ideas from around the world from some of the smartest people to really address how we take healthcare from a broken state to a fixed state. And I know that sounds almost hard to believe that it's doable, but what we're finding from interviewing some of these amazing cast members is that this is fixable. The good news is that we have discovered over the last several weeks, in diving deep into this, far beyond the research of my book, that there are three things. Number one, healthcare is broken. And number two, the good news, it's fixable. But number three, we have to fix it. It's broken, it's fixable, but we have to fix it. And I really think that if we can do nothing more than to change the conversation, to start talking about how we leverage consumerization, how we leverage emerging technologies, connection architecture, models that change the economic incentives towards wellness, prevention, and anticipatory healthcare. I think if we can do these things, we can make a major, major change. So with that, Ray, I'd like to have you introduce Paul and share with us his incredible background, which you shared with me earlier today.
Great. Thank you, Nick. And Paul, it's really great to have you part of our journey on the Healthcare Cure, and look forward to having more collaboration with you over the next number of months, both with the US and in Ireland, with our endeavour to produce this great documentary and indeed a movement to promote the shift towards a health and wellness model rather than a sickness model. For everyone's introduction, Paul and myself have been colleagues and partners now for over 20 years, indeed, when Paul moved to Ireland in 2001. And prior to that, we overlapped when I was living in Western Australia, where Paul hails from, and I'll allow him to do his own introduction in a minute. But what has struck me has been how Paul has brought a lot of his expertise from Australia, and he's now senior partner in a large primary care facility in Dublin and is the head of the communications across 200 clinical colleagues within the Centric Health Group. And one of the aspects which we'd like to talk to about today is the challenge we've had in the C19 era to retain our connectivity with our patients. We're actually 12 weeks into a shutdown in Ireland for the management of the epidemic as it's hit us. And it's been a really fascinating journey because our patients have embraced new technology, just as you alluded to in your introduction, Nick. And now more and more we're using both telephone and video conferencing to communicate with our patients. And we're also now starting to bring our patients back in to us. So, Paul, I'd love you to give your context and introduction, and then perhaps we can have a conversation about our communication access and how it's evolved and matured, indeed, for the better over the last 12 weeks, and their models that we can continue to harness going forward into the future.
Yes, indeed. Thanks very much, Ray and Nick. Great to be a part of this movement and to be a part of this podcast. Paul Carroll is my name. And yes, I'm originally from Western Australia, from Perth, as you said. Spent my first 25 years or so there, and then graduated in medicine, worked in the hospital system in Australia for a couple of years, and then got the wanderlust and went travelling. Ended up in the UK for 5 years, working in various hospital, mainly rotations throughout the National Health Service in the UK. And then my visa ran out and I was about to be deported. So I had to find somewhere else to go. And the only other English-speaking country that would have me at short notice was Ireland. So by quirk of fate, I ended up in Ireland in 2001. And I came for a 3-month working holiday visa over a 3-month working holiday, and I'm still here 20 years later. So that's the attraction that the place has on you. So, and as you said, Ray, now I work full-time in a family physician practice in Dublin, in Ireland. So communication is one of my bugbears, one of my passions, one of my things that I get excited about, because it's all very well people having lots of knowledge. If you can't share it with anybody, then that's a waste of time. So my interest is about communicating both with doctors to patients and to the wider community, and also doctors between each other. There's no point in, again, we've a very good network of over 200 physicians, primary care physicians, but there's no good one of them having a whole lot of knowledge if it's not being shared with the rest of them. So we have increased the mechanisms by which colleagues can communicate with each other by engaging in a lot more dialogue between physicians, and between not only the physicians, but the other important team in the practice as well, the nurses and the administrative team that keep the whole show running. So we have a lot more contacts, and we've set up a twice weekly webinar where representatives of all of those groups join in twice a week that I host, and we share information, share advantages, share knowledge, share developments, share ideas, and try and not have 60 different practices reinventing the wheel. And it works really well. The second angle of it you mentioned there about communication with patients, which is obviously also is very important. And by golly, I've never seen, in my experience, I've never seen the sands shift so quickly as they have over the last 12 weeks. Literally, what's perceived wisdom one day is heresy the next. So it's very hard to keep up with everything. The rules are changing fast, the guidelines are changing fast, and it's a really tricky beast to try and keep ahead of this virus. But I think we're doing a pretty good job. And our patients are thirsty for the knowledge as well. So we have to keep on our toes. We can't bluff on this one, because patients are well informed and they know nearly as much as we do sometimes. There's a lot of very good, certainly in Ireland, there's a lot of very good public health education going on. The chief medical officer is on the nightly news every night explaining this aspect and that aspect, and there's a lot of very good public health information for the general public, who obviously are our patients as well. So that has been a big shift in general kind of knowledge to the general public, and then to our individual patients. Obviously, initially our reaction was to close up shop really and try and reduce the number of people coming in the door, whereas our model would have routinely been, we've routinely seen 25 to 30 people a day, face-to-face, less than 2 meters apart, for 15 minutes at a time, all the things you're expressly not supposed to do. But that was our bread and butter, and that's what we did all day, every day. So we had to turn our kind of business model on its head overnight and get away from that tradition as quickly as we could, because it just wasn't safe to be in the same room as people for an extended period of time if we could avoid it. So that meant that we initially closed the doors completely and really didn't see anybody for a number of weeks, and tried to do everything as much as we could via phone calls and via video calls and via email and as many different other ways as we could. Things have sort of, the pendulum has swung back a little bit, and I'm seeing a lot more patients face-to-face now, but we've got the masks and the gloves, and the room is much more spaced out. There's a lot less stuff around, a lot less clutter in the room, so we can clean it quickly if we have to. And we have the whole kits to wear, should we need to, if we're suspicious that somebody might have this virus. So it's been a whirlwind and a headspin of things just changing so quickly that it's hard to keep up with what's happening in your own practice, let alone what's happening out there in the big wide world. So that's been the challenge. And particularly when you have a group of people, your patients who you are used to dealing with in a certain way, used to interacting with, you have a rhythm and a routine and a method of communication that's comfortable. And then suddenly you have to turn that on its head. And a lot of people didn't like the fact that we were just doing stuff over the phone. They really wanted to come in. And then a lot of people just didn't want to and still don't want to come anywhere near us. because they're...
So you've 10,000 patients in your practice, Paul, in and around that type of number. And what proportion of your day now is face-to-face as compared to teleconference and video conference? And what proportion is between video conference and teleconference? Because you and I were over in Colorado visiting the CPMG group in Denver, the Kaiser Permanente group. And what we found over there was that 60% of the consultations were virtual, and the majority of that 60% were teleconferences rather than video conferencing. So in your new world, what is the breakdown between those three media channels?
Well, it's funny. It depends what day you're asking, because it seems to change very quickly. And there's certainly a push from a lot of our patients to try and get back to the normal as much as possible. A lot of people kind of resent the fact that they have to do things on the phone when they get their most benefit and they see most value out of a face-to-face consultation. So things have swung back from zero face-to-face only a matter of 2 or 3 weeks ago to now. It could be up to 50% of the contacts would be face-to-face, and then about 30 or 40% on the phone, and only about 10 to 20% video at the moment, which I'm a little bit disappointed about, because I was expecting that, like, we had never done video consultations before. I had spent years ranting about how unsafe and how unprofessional they were as a method of communication, and now all of a sudden here I am doing them all day. So even... the rest of us have to swallow our words sometimes. So we've been doing... I'm surprised that it hasn't been a bigger take-up of them, but I suspect that's because most people are still not necessarily at work. But when they go back to work, I think a lot of people, certainly younger professional people, will benefit from being able to just do a video call to us rather than having to take time off, drive all the way here, wait in the waiting room and see us that way. So I'm quietly confident that the video thing will start to pick up again as people get...
And how about your colleagues, Paul? I mean, personally, I had to self-isolate for a couple of weeks for COVID positive tests, and I was nervous going back into a room and having a patient in front of me, and was making sure I was masked for longer than perhaps is necessary, just to be sure. Were you finding that your colleagues were very nervous seeing patients? And did you find that, as you've told me, sometimes the patients were very careful about their masks until they arrived into the room in front of you, and then the game changed?
Yeah. I had a guy this morning who said, he sat in front of me and said, is it okay if we both cheat and take off our masks? I said, well, listen, man, I'm not taking mine off, so you're not either. So every time I have to have the explanation about my mask is not to protect me, my mask is to protect you, and therefore your mask is to protect me. So it only works if we're all doing it. And that's the kind of explanation I give to them all. So, but in terms of colleagues, we've been very lucky, touch wood, that none of our colleagues have been sick. We had a couple of administrative colleagues earlier on, our manager and one of our administrative staff who had symptoms and had to be tested, and in those days it was taken 2 weeks to get a result back, and so we lost them for that time. But thankfully we haven't had anyone since. Now, although we do have an excellent phlebotomist and patient primary care assistant who has been told on advice of her specialist, because of the medication she's on, that she's not to come back anywhere near us for at least the next 4 months, which is disappointing because she's fantastic and we are starting to struggle without her. So it depends more about the individual circumstances of the staff, I think. But look, we just don't know what, you can't see this blooming thing. So we don't know what our exposure is like. We've actually, all the staff in the practice here had their blood taken yesterday for an antibody test to see if we've ever been exposed as part of a survey, a study that one of the local hospitals is doing. So we just don't know what the prevalence, and of course the thing everybody's terrified of, including us, is what's the asymptomatic, how many people out there without symptoms have either been exposed to the virus or have had an infection that they didn't even really particularly notice. So it's a bit like anything. When it doesn't affect you personally, you tend to reduce your level of worry about it. And then when it affects you or your family personally, suddenly it's up there in your face and it's important. So I guess the prevalence in our part of the community anyway has been reasonably low. We've had many positives, but not They all kind of came at once. We haven't had any positives for at least the last 2 weeks. So there's a certain sense that, the crisis is over and we can all get back to normal. All the shops are opening, the pubs are opening, the restaurants are opening soon. And people are saying, well, how come you're not open? And how come your door is locked? And how come we can't get in without a password? So that's...
And Paul, you have a lot of patients with chronic disease, and unfortunately there are patients who are developing cancer symptoms who have been waiting at home and haven't been coming in to see their doctors. So you have actually used your website to try to encourage people to come back to have the perpetual touch with the hands-on experience with their GP. Can you tell us about that?
Yeah, we were starting to worry that, we're a practice of 5 GPs, 5 family physicians, and we're usually very busy. And then there was this period of several weeks where the phone wasn't ringing very much, and people are still getting sick. So it was about, and people were making their own judgment about, am I putting myself at risk of becoming more unwell by going to the doctor rather than staying home and toughing it out? So there obviously is a level of chronic disease that has gone unchecked and unmanaged. We don't have any way of really telling what that is just yet. It's only when people start to come back more that we'll have a handle on what we've really missed. But there's obviously going to be a huge amount of stuff that has either developed further without us being able to see them. And of course, the thing we worry about is early symptoms of diseases like cancer that we would otherwise pick up quickly and early, where time is critical. We haven't, it's an unknown, I guess. We don't know how many of them there are because we haven't seen them, but we know they're out there because they would normally come to us, and they're not going.
So you sent a message out through a little video link. Yeah.
Sorry. So we decided that we had to do as many different things as we could to try and let people know that although the door was closed, we were still open and we're still actively looking after their health. So we went around the practice. We took a little video, stitched it together of all the staff in the practice, chipping in a few lines, basically just saying that we're open, we're still seeing you. Things are different. We're all wearing masks and gloves, but our standard of care is exactly the same, even though we might be doing things a little bit differently. And please, please, please don't hesitate to get in touch with us if you're worried about any aspect of your health, not just the coronavirus. And I was talking to a patient yesterday on the phone who said, I saw your video on the website. And he said to me, I found it very reassuring. I said, listen, Jimmy, you've made my day. I didn't even solicit that kind of feedback. And he said he found it reassuring, which was lovely to hear because we put a bit of work into it. And it's something nice for the staff to be front and center of the communication to the patients, which I think is really important.
Nick described in his introduction the whole area of patient connectivity. And if, say, winding back the clock 4 months ago, if our patients had home monitors for their O2 sats, blood pressure, pulse, temperatures, and were able to give us through kind of like an app their symptom declaration, how do you think that might have impacted on how the COVID disease spread within our community? And in the next 3 to 5 years, do you really believe that connected technology and that perpetual touch with our patients will be transformational with regards to how our access of integration with our patients can be improved?
Well, it's a good question. Obviously, what we're terrified of is a tsunami of data that could come if everybody had wearable devices measuring every conceivable parameter that would be dumped on us to interpret. Now, that's probably a worst case scenario. But to answer your question about what would have happened if people had such things, I mean, the big thing that would have made a difference, I think, personally, would have been the oxygen saturation. If everybody had an oxygen saturation monitor at home, we would have been able to cut to the chase a lot quicker with people who were suspected of having either of having the virus or of having an exacerbation of their because really a lot of the times they were coming to the doctor basically just to have their oxygen saturation level checked. And if their level was good, they could just go back home and tough it out. And if their level was low, then they needed to be in hospital. So that was the critical piece as far as we were concerned, that nearly everybody just didn't have access to at home. So that would have made a big difference, I think. In general terms, I think it's a very personal thing in that I spend a lot of my time telling patients to stop measuring their blood pressure, because sometimes, particularly people who are a bit anxious, the more they measure their blood pressure, the more it just goes up and up and up. So I think it has to be the right person measuring their blood pressure for the right reason at the right interval. So it's a useful thing. And like everything in medicine, I was always taught you don't do any test for any reason whatsoever unless the outcome of that test is going to change what you do. And I'm constantly battering that into patients as well, who go off and buy all these things. So look, there's no point in measuring things every hour of every day if what the result is not going to change what you do. So I'm interested in your average blood pressure. I'm not interested in every measurement of every minute of every day. And some people sometimes can get a little bit more worried about the results than they are about the symptoms. So it has to be individualized, and that's the key to it. I think you have to pick your targets in terms of who's going to be able to use this kind of technology in the most appropriate way that will actually benefit them and benefit us to help make the right decisions about their medication and their healthcare, rather than people just doing a whole lot of readings for no apparent purpose. So I think it has to be tailored to the right person at the right time for the right reasons, and measuring the right data.
And Paul, you're part of this movement now with us for fixing healthcare and the healthcare cure. How do you feel that we can, between countries, Ireland and the States, and indeed your homeland in Australia and Israel, where we're connecting with some of the kind of groundbreaking technology, how do you think we can learn from each other? Because you've lived and worked in a number of countries now, and are you a real proponent of that sharing of experiences across countries and nations?
Absolutely. I think as I was saying before, there's no point in one doctor having knowledge if nobody else has it. And likewise, no point in one medical system or one country having knowledge. And having worked, as you said, in a number of different countries, in a number of different settings, a number of different continents, I think each system has its advantages and disadvantages. And I've never worked in a perfect healthcare system. I'm sure there's probably one out there, but I haven't found it. Some are better than others, and some have very good strengths, and all of them have weaknesses. And I guess it's about tailoring the attitude and the approach that you have to make the most out of the system that you're in. Bearing it, you have to be aware of its strengths and its weaknesses, and you have to play to the strengths and try and work around the weaknesses as much as you can. And that's as much an issue today where I practice in Ireland as it was when I worked in Australia and in the UK. I don't know enough about the Israeli health system, and I look forward to finding out more about it. And
well, it's really very similar, Paul. We were talking to Dr. Yossi, who is going to be part of the documentary. And fundamentally, the reason that you love being a GP is the connectivity that you have with your patients. And isn't that what transcends every national border, and is what really is the reason that you're doing what you're doing every day?
Absolutely. I'm conscious that my colleagues in the United States don't necessarily work in the same sort of system, in that we're very conscious and very keep great store in the fact that we are the gatekeepers, and you can't get to a secondary care service without going through a primary care physician or a family physician in our system. And a lot of people disagree with that. A lot of people don't like that's the way it is, but I think it works well for us. And again, it's a strength of the system, but it can also be a weakness because people have to go through a number of hoops to get somewhere that they think they should be able to get to straight away. And in many cases, they're absolutely right, but not always. So we've all got things to learn from each other, and that's the beauty of it. And unfortunately, you never get to the end of the journey. It's always ongoing, and we can always keep learning. And that's what I've found so far, and I only hope it's going to continue.
All right, guys, thanks so much. That was a great insight. We're seeing this across the world where the C-19 or the post-COVID-19, however you'd like to characterize it, has really done two really important things that I think are very, very positive. First, generally in healthcare, the healthcare industry has suffered from what I call legacy latency. right? They've done something for so long that they're extremely reluctant to make any changes because, generally speaking, it's comfortable and change has potential risk. I think one of the great results from all this is that we've started to tamper with legacy latency. And now we see organizations, and I just had a great conversation with one of the major hospital systems here in North America yesterday, is we're seeing tremendous amounts of speed and a willingness to be open to the fact that things need to change if we want to make things better. I think another really great advantage of what has happened in this current environment is that it has made innovation a mandate. It's said that we need to take a look at clinical models. We need to take a look at the way in which we engage patients, to the point of wearable technologies. We can't look at lots of disparate biodata sets, but the learning machine can. And the learning machine can set appetites for risk reportability. It can look at many, many disparate signals, including pulse oximetry. It can look at core body temperature. We're even starting to look at things like head AI. In other words, the science of understanding head movement and its potential connectivity to certain forms of neuropathology. We're looking at, we're starting to add some really cool things to telemedicine. It used to be that telemedicine was seen as subtractive. But today, through facial AI, we can actually determine human mood state and stress based on facial recognition technology. And this isn't theoretical. It's now being shown very, very deeply to provide information about the lucidity of a patient, neuropathology, even potential risks of things like dementia and Alzheimer's. We're starting to look at breath AI, being able to monitor breath and looking at the nanoparticles within breath to understand deep, rich information that we never would have dreamed to see before. And what I like as somebody who has worked with most of the drug and device companies and hospitals around the country, I love the fact that we're starting to exit this concept of legacy latency and moving on towards the innovation mandate with the goal of improving the way in which we predict and prevent illness rather than having the trigger mechanism of hyperintervention, that sort of automatic prescription trigger mechanism that seems to happen. Well, listen, I loved watching your video this morning and really love the way in which you've reached out and connected with your patients. We have a patient that wants that level of human connection while at the same time knowing that the caregiver has the technologies and the systems, not just to keep them safe, but to be able to help them move in a journey of wellness and prevention. And I love your model. I was really inspired. And in fact, with your permission, I want to share this with some of my colleagues as a great example of what it means to really create that beautiful, emotive, and human connection. Paul, I love your story.
Don't let him get carried away, though, because he does have a face for radio, Nick.
Right.
Yeah, you're right about that.
Well, Paul, listen, I really enjoyed your story. I love your insights. I love the great work that your clinic is doing. It's an honor to have had the chance to meet you. And I'd like to thank you both again for taking time away from your busy lives to be able to share some time on today's Healthcare Cure podcast.
You've been listening to the Healthcare Cure podcast. Don't forget to visit our website at thehealthcarecure.com. And thanks for listening.